Then we will go ahead with the miscarriage, NICE management. Okay, NICE guideline as such. So early pregnancy. So in UK, in NHS, there are early pregnancy unit. So these early pregnancy unit deal with the early pregnancy complications and the management of the normal physiology of the early pregnancy. Okay, so how these early pregnancy assessment services are provided? So regional services should be organized so that there is an early pregnancy unit assessment available 7 days a week for women with early pregnancy complication, where the scanning should be carried out and decisions about the management is made. An early pregnancy assessment should be dedicated service provided by health professionals competent to diagnose and care for women with pain and or bleeding in early pregnancy, and offer ultrasound and assessment of beta HCG levels, and be staffed by the healthcare professional. So in this basically early pregnancy unit or early pregnancy clinic, these are managed by the specialist people, and early pregnancy complications, they are managed. The facility for the ultrasound is also available, and the facility for the beta HCG is also available. Okay. Now, what are the symptoms and signs of ectopic pregnancy and the initial assessment? So we have to refer these patients with significant pain, bleeding, or hemodynamic instability to accident and emergency. Okay. Ectopic pregnancy can present atypically with varied symptoms. Even uncommon ones may be important. So symptoms of ectopic pregnancy are divided into two. One is the common symptoms, another is the rare symptoms. Commonly will be abdominal or pelvic pain, amenorrhea or missed period, and vaginal bleeding with or without clots. So these will be the common symptoms. And other reported symptoms, there can be breast tenderness, GI symptoms will be there, dizziness, fainting, syncope, shoulder tip pain, urinary symptoms, passage of tissue, rectal pressure or pain on definition. From part to point of view, this will be the scenario description will be given. But for part 3 candidate, you need to ask certain things when you are having a task on either ectopic pregnancy or the early pregnancy. Okay, so these symptoms you need to ask. Second, what are the signs of ectopic pregnancy? They are divided into more common signs and the other reported. Common one are the pelvic tenderness, adnexal tenderness, and the abdominal tenderness. Okay, and other reported signs will be cervical motion tenderness, rebound tenderness, or the peritoneal signs, pallor, abdominal distension, enlarged uterus, tachycardia more than 100 beats per minute, or hypertension less than 100 by 60 millimeters of mercury blood pressure. Patient may be in a shock or collapse and a orthostatic hypotension. Okay. Most important, in women of reproductive age, consider pregnancy even with non-specific symptoms, as ectopic pregnancy can mimic GI or urinary conditions also. So pregnant patient may present with some GIT or urinary complaints, but we need to think about the early pregnancy when the ectopic pregnancy when the patient is in a young reproductive age group. That is what the NICE guideline says. So all healthcare care professional should have access to the pregnancy test, immediately refer women with positive test, abdominal or pelvic or cervical motion tenderness to early pregnancy clinic or the early pregnancy assessment unit, and out of hours they should be referred to the gynecology service. Okay, so always, so referral, where should be the referral of these ladies? It should be either early pregnancy unit, and if the patient is presenting in the out of our services, then the gynecology referral. Okay, always
Okay.
consider ectopic pregnancy even without risk factors, as one third may not have any risk factor. Again, this can be asked as a SBA, that one third patient may not have any risk factors. Okay, so refer women with early pregnancy symptoms, pain, more than 6 weeks of gestation or uncertain gestation to early pregnancy and out of hours to the gynecology services. Okay, now suppose you have patient. This is again a SBA which has been frequently asked. What is the next step or what is the management? Okay, so uh, for patients who is less than 6 weeks of gestation, she's coming with bleeding, but there is no pain. Remember, early pregnancy complication. You always look into the history, which is scenario which is given to you. Is there a bleeding and is there a pain? Bleeding plus pain, think of ectopic. There is a bleeding, but there is no pain, and it is a less than 6 weeks of gestation. In that particular case, you go for expectant management. This is the most important thing you remember. Early pregnancy, there is a bleeding, but there is no pain. You go for expectant management. Okay. Expectant management is the continue the routine care. Okay. Advice written if bleeding continues or pain develops. repeat UPT 7 to 10 days. Okay, so this is the option which they give you. When will you repeat? They will give you the repeat UPT after 7 days, repeat UPT 7 to 10 days, repeat UPT after 2 weeks, repeat UPT after 3 weeks. Okay, if there is a bleeding, if there is no pain, and it is less than 6 weeks, repeat UPT after 7 to 10 days. If the test is negative, that means the pregnancy has miscarried. If the test is positive, return for assessment. Okay, refer for refer women with worsening symptoms suggestive ectopic pregnancy to early pregnancy or out of hours to the gynecology service. Urgency, that is immediate or within 24 hours, depends on the clinical condition. How much urgent will depend upon the clinical condition. See, if normally we are immediately going for the ultrasound, but here they are talking about repeat UPG because according to this guideline, you have an early pregnancy, the patient is not having pain, so and there are no other high risk factors. Okay, in that particular case, we are not suspecting the ectopic pregnancy, so we go ahead with the conservative management. However, if the patient is having worsening of the symptoms suggestive of ectopic, then you will refer. You got it. So if the patient is otherwise low risk, the next management will be repeat UPT after 7 to 10 days. Okay. This, please remember, early pregnancy, no bleeding, no bleeding, no pain. Okay. So again, this is again important from SBA point of view. Diagnosis of viable intrauterine or ectopic pregnancy. Okay. So ultrasound use and approach. What is the modality of choice? TVS is the modality of choice. TVS will be helpful for us location of the pregnancy and for diagnosing getting the fetal pole and the heartbeat. Okay. Transabdominal only when the uterus will be enlarged or there is an associated pelvic pathology like fibroid, ovarian cyst, then only you go for the transabdominal. Otherwise, go ahead with the TVS. Okay. If the transvaginal the patient is declined, then you will offer transabdominal scan, but at the same time, you will explain the limitations of the scan. Okay. Transabdominal scan has got a limitation. Okay. So ultrasound scan findings and follow-up. Okay. Diagnosis of miscarriage via single scan is not 100% reliable, especially in very early gestation. If fetal pole is visible but no heartbeat, then you have to measure the CRA. Okay, now you are doing a TVS and there is no heartbeat. Okay, the fetal pole is visible, but there is no heartbeat. Then what will you do? You have to measure the CRL and further management will depend upon the CRL. Then you concentrate on this particular table. Okay. So you measure the CRL. Your CRL is less than 7 millimeter. What will you do? You will repeat the scan after 7 days. Okay. If the CRL is more than 7 millimeter, you will ask for second opinion and or after repeat the scan after 7 days. Okay, this is what is the next step. They ask you the next step. They'll give you that the patient has presented in such and such way. You have done the TVS and the CRL is 7 millimeter. They'll give you exact 7 millimeter. That means it fits here. Okay. If they give you 6 millimeter, then your management will be repeat scan after 7 days. Because if it is a TVS, you have to repeat the scan after 7 days. You are not able to see the fetal heartbeat, so you will repeat the scan. But if it is a more than 7 millimeter or a 7 millimeter CRL, then you have to take a second opinion. And if they mention that your second opinion has also been taken, then you will repeat the scan after 7 days. Because the guideline says diagnosis of miscarriage via single scan is not 100% reliable. Okay, especially in very early gestation. So they are you have to be very, very sure that you are diagnosing the miscarriage properly. Okay, so less than 7 millimeter, obviously straight away you go for repeat scan after 7 days. But if it is a 7 or millimeter CRL, then you take a second opinion and repeat the scan after 7 days. Okay, or you can repeat the scan after 7 days also. If the second opinion is not available, then you will repeat the scan after. But even if you do the second opinion immediately, then also you will repeat the scan after 7 days. So this you remember, they ask you the next step. So one question generally in first 10 of SBS in paper 1, you will find this kind of SBS and is either on UPT or this. Okay. Now, suppose you are not doing a TVS, you are doing a TAS. Okay, sorry, you are not you are doing the TVS but not measuring the CRL. The findings which are given are the mean sac diameter. Okay, now if you are dealing with the mean sac diameter, then the mean sac diameter cutoff is 25 millimeter. Okay, if your mean sac diameter is less than 25, then you will repeat the scan after 7 days. If the mean sac diameter is more than or equal to 25 millimeter, you will take the second opinion, and or you will repeat the scan after 7 days. Okay, so what you have done, you have done the TVS. Then on TVS, you can measure the CRL or the GSAC, the mean sac diameter. If it is a CRL, then 7 millimeter, less than 7 millimeter, repeats after 7 days. But if it is a mean sac diameter which is given, then the cutoff is 25 millimeter. So if it is less than 25 millimeter, again the management is same. Okay, if it is more than 25 millimeter, then you have to take the second opinion and or repeat the scan. So only what is the difference here? When you measure the CRL, the cutoff is 7, and when you measure the mean sac diameter, the cutoff is 25. Otherwise, management remains same when you do the TVS. But now when you do the transabdominal, you have got a no heartbeat, but you have measured the CRL, then you will repeat the scan after 14 days. Instead of 7 days, you will measure the scan after, you will do the scan after 14 days. So that is what is the difference between the transvaginal and transabdominal. So when you are given a scenario, look what finding, what kind of ultrasound is done, whether they have done the TVS or whether they have done the transabdominal. If the transabdominal and they have given the CRL, then also it is 14 days. If it is a, they have measured the mean sac diameters, you will record the mean sac diameter and you will repeat the scan after 14 days. So is it clear to you when there is a transvaginal and transabdominal, how much, how it differs? Okay. So
Yes, sir.
one of the important clinical note is that do not rely on the LMP alone, because gestational age to assess the gestational age or determine the when the heart rate should come. Okay, only LMP is not reliable. So LMP may not be accurately dating the pregnancy due to cycle variability, and waiting for repeat scan does not harm the pregnancy. So always repeat scan is advisable. Okay, so what you have to do, you have to give the 24-hour contact number for support and advice and additional written information as per guidance. Actually, for part two, this information is going to be informed. When you are dealing with the patient, you have to give these kind of advices. Okay, you will tell that she should contact on this number anytime if there are red flag signs. Okay, now up till now, what we have seen, pregnancy of unknown viability. That means early pregnancy was there on the scan, but the fetal heart rate was not there. Okay, that management we have seen. Now it is the diagnosis of complete miscarriage. What does the guideline say? If no prior scan confirm the intrauterine pregnancy and complete miscarriage is suspected, consider pregnancy of unknown location, arrange follow-up SCG, and repeat scans until the diagnosis is confirmed. So on a single scan, don't just think of the complete miscarriage. You always keep in mind that it can be a pregnancy of unknown location also. So you will advise the beta ICG and the repeat scan until the diagnosis of complete miscarriage is confirmed. Okay. Now, what are the signs indicating the tubal ectopic pregnancy on ultrasound? Okay, the highly diagnostic certainty is with you have when you have an adnexal mass which is moving separately from the ovary, and it has got a G-sac and yolk sac, or it has got a G-sac and fetal fold, which may have the cardiac activity, may or may not have the cardiac activity. So adnexal mass, which is moving separately from the ovary with G-sac and yolk sac, or fetal fold with or without fetal cardiac activity, that has got the highest diagnostic certainty. Then there are other signs which are suggestive of possible ectopic pregnancy. That in that case, you may not see the adnexal mass as such, but what you will see, the uterus is empty. There may be intrauterine fluid collection, that is pseudosac. Okay, differentiate from a true gesture sac by checking for eccentric location and double decidual sign. There are two signs. This one is a intradecidual sign, and second is a double decidual sign, also called as DDS. Okay, so they are present in the intrauterine pregnancy, while ectopic pregnancy will have the pseudosac. Okay, so that in such cases you will again assess with the scan findings, symptoms, and serum SCG. Okay, then signs indicating high probability of tubal ectopic support the diagnosis but requires correlation. So you will have the adnexal mass which moves separately from the ovary along with the empty G sac, called as a either tubal ring or a Bagel sign or a complex inhomogeneous adnexal mass. Always consider other scan features, clinical presentation, and serum SCG before diagnosis. Okay, so this last time we have discussed when we were discussing the GTG in the last lecture. What is the commonest presentation? The commonest presentation is a inhomogeneous adnexal cystic mass. Okay, so that was the presentation which is the common. Now there are two signs which will differentiate ectopic from the intrauterine. One is the intradecidual sign, second is a double decidual sign. So the double decidual sign is a specific ultrasound feature which is seen in early intrauterine pregnancy, usually around 4.5 to 5.5 weeks of gestation. It helps to distinguish true intradecidual G-sac from the pseudo-sac, which can be seen in ectopic pregnancy. Okay. Now, key ultrasound consideration in early pregnancy. Always check for the free fluid in the peritoneal cavity or pouch of Douglas. However, this can be present in intrauterine pregnancy also. Okay. Then moderate to large amount may indicate hemoperitoneum. Okay. Correlate with the scan findings, clinical presentation, serum SCG before diagnosis. Assess for heterotopic pregnancy. Always scan both the uterus as well as adnexa during early pregnancy. Ultrasound must be performed or reviewed by qualified professionals trained in diagnosing ectopic pregnancy. Now, this slide is not important from the examination, but it is going to be very, very important from practical point of view. When you do the scan, just don't look at the uterus and look for the intrauterine pregnancy, or even if you say GSAC, think of whether it can be pseudosac. Always look at the adnexa also. That is what is the importance of this particular slide. Okay. Now, what are the general principles in pregnancy of unknown location? Okay. Now, this particular concept of pregnancy of unknown location is going to be very, very important because they ask you the question on this pregnancy of unknown location. They ask the next step. Okay. So, in pregnancy of unknown location, what is the principle? Assume ectopic pregnancy until confirmed otherwise. Assume that you are dealing with ectopic pregnancy, unless it may be coming as an intrauterine also. Okay, so assume that you are dealing with ectopic pregnancy until confirmed otherwise. Do not use serum SCG alone to determine pregnancy location. Okay, clinical symptoms are equally important as SCG levels. Okay, and reassess if the symptoms change. Serum SCG only to assess tropoplastic activity and guide further management. Okay, so alone SCG is not useful. You have to look into the clinical symptoms also. What is the SCG monitoring protocol? You have to take two SCG measurements, which are 48 hours apart. Okay, for guiding the management. So what, and you have to see how much is the increase or the decrease. Okay, so if there is an increase which is more than 63%, it is likely to be developing intrauterine pregnancy. Okay, so more than 63% rise, it is likely to be an intrauterine pregnancy, but still ectopic cannot be ruled out unless you do the TVS. Okay, so in that particular case, you will do the TVS in 7 to 14 days or earlier if the beta SCG is more than 1500. If the viable intrauterine pregnancy is there, she will go for routine antenatal care. If it is not viable, then urgent senior review will be done. So they will ask you then what is the next step. Okay, here you will do the beta SCG after 48 hours. If there is a more than 63% rise, that means likely to be intrauterine pregnancy. So what you have to do? Repeat TVS in 7 to 14 days. Okay. Remember this 7 to, because the options will be TVS in 7 days and TVS in 7 to 10 days. Previously, what we have seen, UPT in 7 to 10 days. When there was a bleeding and early pregnancy, less than 6 weeks, but there was no pain, we will do the UPT in 7 to 10 days. Okay, I'll go ahead back. I'll go back again here. Okay, repeat UPT in 7 to 10 days. So when you have multiple confusing options, 7 days, 7 to 10 days, 10 days, 2 weeks, such kind of options. That is why you need to be very, very sure. Here it is a 7 to 10 days of UPT when you are dealing with this scenario. Now you are dealing with the pregnancy of unknown location. You will do the TVS in 7 to 14 days. Okay. So this you have to be very, very specific. So if you get a viable pregnancy, you are likely to get viable pregnancy because there is a good rise. Then you will go for routine antenatal care, if not urgent senior review. Okay. Now the beta HCG is decreasing. After 48 hours, you have got a very good decrease. More than 50% is a decrease. It is unlikely that the pregnancy will continue. Then you will support, do the counseling of the patient, and you will repeat UPT in 2 weeks, that is 14 days. Okay. So repeat UPT after 14 days. If it is negative, no further action is required. If it is a positive, she will return for review within 24 hours. Okay. So this management you should remember. If there is a beta HCG, what is advisable? You have to repeat UPT in 2 weeks time. In previous scenario, early pregnancy, 7 to 10 days. Here it is 2 weeks. Okay. Then if there is a decrease which is less than 50%, or there is an increase but increase is less than 63%, in that case the trend is uncertain. We do not know whether it is going, what is going to happen with this pregnancy. So refer for clinical review in early pregnancy unit within 24 hours. So these cases will require referral to the early pregnancy assessment clinic. Okay. So this is the given by the NICE guideline. Okay. There is another way of M4 model. Okay. That I will be discussing along with another talk which is there. Okay. So that I will discuss later on. But this is relatively simple to understand. The M4 model is little difficult to understand. It is given that is the management of pregnancy of unknown viability. Okay. Pregnancy, sorry, unknown location. There are two ways. One, this, as per the NICE guideline, go for this beta HCG 0 hour and 48 hours and use these criteria. Other is a M4 model that I'll be talking separately. Okay. Now coming to the management of threatened miscarriage. Okay. Now, if the fetal heartbeat is confirmed in a woman with vaginal bleeding and no prior miscarriage, you will continue with the routine care. Okay. So advice written if bleeding worsens or persists for more than 14 days. If the bleeding stops, continue with the routine antenatal care. Okay. If the fetal heartbeat is confirmed and woman has had a previous miscarriage, now she has come with a threatened miscarriage. There are two scenarios. One scenario is that in one scenario, there is no previous history of previous miscarriage. In another scenario, there is a previous history of miscarriage. If there is a previous history of miscarriage, then what you will do? You will advise micronized progesterone 400 milligram BD vaginally up to 16 weeks of pregnancy. While if there is no history of previous miscarriage, you will continue with the routine care if the bleeding stops. If the bleeding does not stop, she will come for follow-up. Okay. So this is what is the management. They always ask you what is the next step. So you look for what is the finding which is given. Now, the previously it will be scenario of pregnancy of unknown location. That means the beta HCG will be positive and the scan is inconclusive. Okay. There will be no intrauterine or extrauterine pregnancy. Then you will go for this kind of management. In another, you will have intrauterine pregnancy with fetal heart rate, but there is a bleeding. That means you are dealing with the threatened miscarriage. Then look for history, obstetric history. Is there a previous miscarriage or no previous miscarriage? Previous miscarriage, offer her micronized progesterone 400 BD vaginally till 16 weeks. No history, routine antenatal care. Okay. So this is what is the management. Now coming to the expectant management for miscarriage. Okay. Now you have got a confirmed miscarriage. Okay. Now there are three types of management. One is a expectant management, another is a medical management, and third is a surgical management. These are the types of management which are available in the miscarriage. Okay. So what does the guideline say? Guideline says the first line approach is the expectant management. Offer expectant management for 7 to 14 days if in a confirmed miscarriage. Okay. And the alternative options, that is medical or surgical, will be preferred if there is a risk of hemorrhage, that is, it is a late first trimester pregnancy, or there is a history of traumatic pregnancy loss, or risk from the blood loss, that is bleeding disorder or refusal of transfusion. In that case, this expectant is not preferred. Okay, you have to select the alternative one, medical or surgical. But they have when there is a another one scenario they have asked in the I think SBA, it is asked, they where the patient is having some bleeding disorder and it is a miscarriage, and what is the preferred management. There little confusion is there here. Expectant is not preferred, but what is preferred, whether medical or surgical, that is little confusing. Okay, so risk for the so these patients, like patients with infection, they are not suitable for the expectant management. Okay, if expectant management is not acceptable, then go for the medical management. That is what the guidelines says. So if the expectant management is not acceptable, then you will go for medical management. So in that particular scenario which I discussed, maybe the medical management will be the suitable, because they say that if expectant management is not acceptable, then you go for medical management. Okay. So what should be the counseling and follow-up for the expectant management? Explain expectant management clearly, including that most do not need further treatment. Provide oral and written information on what to expect, pain relief options, and when and where to seek the help. So you have to tell the patients all these things. Okay. Now, if the miscarriage completes within 7 to 14 days, expectant management is for 2 weeks. 7 to 14 days, you have to wait. Okay. Then give urine pregnancy test to use at home after 3 weeks. Okay. Again, here the question is when to do the UPT, from the diagnosis or from the 7 to 14 days. Okay, so actually, logically speaking, once the miscarriage is complete, then after that you have to wait for 3 weeks and do the urine pregnancy test. Okay, so if it is a positive test, she will return for individualized care. And if bleeding pain has not started or is persisting or worsening, you will offer repeat scan. Okay, discuss all options, that is expectant, medical, surgical. And for those continuing expectant management, review condition at minimum 14 days after the initial follow-up. So uh, expectant is up to 2 weeks. Okay. If it is complete, you will repeat UPT after 3 weeks. But if it is not complete, or if the pain has not started, then first thing what you will do, you will repeat the scan. Okay, and you will see whether she is suitable for this medical whether she is suitable for further expectant management, and continue the expectant management another for 14 days. Okay, so that is what is the expectant management. Next management is a medical management of missed miscarriage. What is there? You give mifepristone 200 milligram orally, and after 48 hours, you will give misoprostol 800 micrograms, either vaginal, oral, sublingual. Okay. Here, remember the dose for missed miscarriage, 200 mife, and 48 hours after misoprost is around 800. All three routes it can be given. Do not give if the GSAC is already passed. If no bleeding within 48 hours of misoprostol, advise the patient to contact the healthcare provider. If follow-up is uncertain, service should initiate the contact. So medical management of incomplete. Now, if you have got a incomplete abortion, then the dose is not 800, dose is 600. Okay, and no mifepristone is required. So for incomplete miscarriage, you will give misoprostol 600 microgram instead of 800, vaginal, oral, or sublingual, or you can give 800 also, but mifepristone is not required, because if you give 800, the protocol will remain same, except the it is easy to remember the same protocol except mifepristone. Okay, that becomes the alignment of the protocol. Do not use mifepristone for incomplete miscarriage. Now, what is the follow-up after the medical management? Even for medical management, give a urine pregnancy test to use 3 weeks later unless symptoms worsen earlier. Same management. You have to repeat UPT after 3 weeks. Okay. If the test is positive, advise return to review to rule out either return pregnancy, molar pregnancy, ectopic pregnancy. If the test is negative, but there are ongoing symptoms like bleeding, pelvic pain, etc., assess for further investigations treatment. Okay, if the test is negative but there are symptoms, you will have to assess the case. Now, what is the general information for all women with ectopic pregnancy? We will provide all oral and written information. This is important from part 3 examination point of view. Okay, what exactly you are going to talk, treatment options, and what to do, what to expect, that we need to discuss, whom to contact for post treatment advice, when and where to seek emergency care, inform women they can self refer to an early pregnancy assessment unit in future pregnancies if early concerns arise. Okay, now what is the eligibility for expectant management? Expectant management, if all the following will apply, woman should be clinically stable and pain free. Okay, this is what is the ectopic pregnancy. Up till now, what we have seen was the incomplete miscarriage and the threatened miscarriage, etc. Now they are talking about the ectopic pregnancy, expectant management. This also we have covered with the GTG. The tubal ectopic mass should be less than 35 millimeter. No fetal heart. Okay. Serum SCG should be less than 1000 millimeter, 1000 international units. The patient should be able to return for follow-up and consider expectant management if all of the above apply, but serum SCG is between 1000 to 1500. So uh, between 1000 to 1500, you consider the expectant management, and up less than 1000, you offer the expectant management. And all the criteria should be fulfilled, that the patient should not have pain. Ectopic should size should be less than 35 millimeter with no fetal heart rate. Okay. And these all, and most important, the patient should be ready to come for follow-up. Okay. And what is the monitoring protocol here? The remember, the monitoring protocol for the expectant management is different, and monitoring protocol for the medical management is different. Here we are repeating the beta HCG on day 2, day 4, and day 7. In medical management, we are repeating the beta HCG on day 4 and day 7. While in expectant, we are repeating the beta HCG on day 4, day 2, day 4, and day 7. Okay. If the beta HCG is decreasing more than 15% from previous value, we will continue to monitor beta ICG weekly till it becomes less than 20 international units per liter. The same thing we have discussed along with the GTG, but the value which was given here, that continue the weekly beta ICG monitoring, there they have mentioned 15 international units per liter, while in NICE guideline they mention that continue the weekly beta ICG until 20 international units per liter. Okay, so initially you will give 2, 4, 7. If there is a beta ICG in decrease more than 15%, you will monitor weekly till it becomes less than 20 international units. Okay. If no significant drop or rise, or there is a plateau, you will reassess and you will seek the seniority. Okay. Now, what are the counseling points? Inform women that based on limited evidence, whether you go ahead with the expectant management and medical management, there are similar rates of natural resolution, comparable risk for tubal rupture, no major difference in the need for additional treatment, no difference in the health risk, anxiety, or depression outcomes. So all these parameters are same whether you go ahead with the medical management or expectant management. And fertility outcomes and time to resolution are likely similar in both the approaches. Okay, so there is no much difference in both the management. Okay, now coming to the medical management, this also we have covered along with the GTG. There should not be any significant pain. Adnexal mass should be less than 35 millimeter. No fetal heart rate. The serum beta ICG should be less than 1500. Okay. No intrauterine pregnancy. Women should be able to return for follow-up. Definitive diagnosis of ectopic pregnancy is confirmed. If methotrexate is not acceptable, then you go ahead with the surgical management. Okay. Now, what between the 1000 and 1500? Okay. So this is expectant is up to 1000. Up to 1000 is expectant, but can be offered up to 1500. Okay. Medical is up to 1500, but can be offered up to 5000 also. So between 1000 to 5000, you have the choice of medical or surgical management, provided other criteria like no significant pain, adnexal mass less than 35 millimeter, no fetal heartbeat. If these all are satisfied, then you can still give the methotrexate. So between 1000 1500, you have the choice between the medical and surgical management. So when they give you the long scenario, and only beta hcg may be 2500, but the rest of the criteria is in the medical management. So there also you can offer the methotrexate. Okay, so if methotrexate is chosen, counsel on a higher chance of needing further intervention or emergency admission. Monitoring after methotrexate, here you remember, here there is a difference: day 4 and day 7 after the treatment, then weekly till scg becomes negative. If scg rises or plateaus, reassess and then consider further treatment. Okay, now the last option, surgical management. This we have gone into the detail completely along with the GTG. Offer surgery as a first line if woman cannot return for follow-up, significant pain, adnexal mass more than 35 millimeter, visible fetal heart rate, serum beta ECG more than 5000. Laparoscopy, two approaches, either salpingostomy or salpingectomy. That also we have seen. What is the persistent beta ECG, beta ECG, persistent trophoblast and all that we have seen. So salpingectomy and salpingostomy, that we have already seen. So I will not go into the details when to perform, but up to 1 in 5 may need additional treatment when you go ahead with the salpingostomy. Okay, so there is a 20% chance that the patient who you perform salpingotomy, there is a 1 in 5 may need additional treatment. So this is a SBA which has been asked in the past. Okay, so follow up after surgery, after salpingotomy, you will do the beta ECG 7 days and then weekly. Okay, after salpingectomy, you have to do the UPT after 3 weeks. Okay, so these follow-ups are going to be, there are so many follow-ups up till now we have seen. Okay, so that finishes the topic of ectopic pregnancy and miscarriage from the NICE guideline. Okay, thank you.